Good morning, ladies and gentlemen. So it's my great pleasure to present this case. So this case, he's a 29 years old male. He was involved in a car accident and sustained injury to his right leg, and no other associated injury. But the underlying disease is asthma and the morbid obesity. The BMI is about 49. His weight is 150. So his height is 125. So this is the X-ray of the patient. This is the only image that we can get because the thickness of the soft tissue. So and this is how the patient look like. So what I think at that time is what kind of the operative table that I'm going to use, and what kind of position of the patients that I'm going to put when I operate it, and what kind of fixations, and how to reduce the fractures. And the most important thing is how reliable of this patient post-operatively. So I decided to use the cephalomedalline nail. This is after 3 attempts of intubation because the thick neck and the short neck, and we did the general anesthesia combined with the regional anesthesia, and I put the patient in the radiolucent table and use the bean bag in order to make a little bit movement if I would like to reduce the fractures. And this I put the C-arm fluoroscopy from the opposite side, and to make sure that I can get a good image intensifier. This is the lateral X-rays of the hip, and this is the AP X-ray of the hip. And I would like to make sure that there is no overlapping of the both sides of the femur on the lateral side. So I later put the patient a little bit more, not a true lateral decubitus. So, and for the entry point, I use a Steinman pin to make the good entry point at the trochanteric entry point. And I follow by the curve R and use the T-lemur. T-lemur, I think, is a good friend for make the entry point at the proximal femur. And then I proceed to use the ball tip guide wire. And I did not hesitate to make it open wound to reduce the fracture, and use the clamp to reduce the proximal fragment, and use the collinear reduction clamp because there is a large medial fragment of the subtrochanteric lesion. And I keep it until I ream the femoral canal, and I put the nail in, and I put the lag screw in. I decided to use the single large lag screw instead of the helical blade because I was afraid of the push after we hammering the helical blade into the proximal femur in young patient. And this is the X-ray intraoperative look like. After a couple of days in the hospital post-operatively, I transferred him back to the nearby hospital, like at the hometown hospital. And I strongly recommend him not to put the weight on his leg, just only touch down with bearing. After 1 month, I make a phone call and ask him. He said, "Hey doc, I'm doing great. I never put the weight on my leg because I'm walking on my knee." So he walked on his knee. So this is the post-operative 6 months. So this is how the patients. This is the post-operative 6 months. I asked my friends from that hospital to take pictures of these patients. His weight is still 130, so he reduced 20 kilograms in 6 months. That's good. And thank you.